There we go. So, good morning or afternoon, depending upon where you are across the country and even the world. As we've had people from all over the globe attend webinars in the past. Before we go into today's webinar, I want to take a moment to express my appreciation for your participation. My name is Dr. Jeff Greenberg. I have the privilege of serving as the director of the Eating Disorder Center of Excellence. As many of you know all too well, eating disorders are some of the more complex behavioral health conditions to address. They can be notoriously difficult to treat, and while they impact nearly 30 million Americans, they can be terribly isolating for individuals who experience these conditions and for friends and family. Research demonstrates that while nearly 9% of Americans are affected by these conditions, public awareness remains low. And as with all behavioral health conditions, clinical resources tend to be insufficient to meet the demand. Even as I say this, I'm hopeful. I'm hopeful because you've chosen to be part of this fight, because you committed to supporting those who are affected, and because together we're building a true community. As the message spreads, it's my hope that the public becomes more broadly aware of eating disorders, that providers become more motivated to learn best practices, and that resources become more available for friends, families, and communities. I consider each of you who have registered or attending these webinars to be valued colleagues in the broader community, committed to improving the lives of those who most need our support. It's through this community that we'll make an impact, deliver hope, and work towards a future. Work towards a future where we focus on preventing eating disorders as opposed to responding to them. Today, you'll hear a presentation focused on school healthcare providers. You are also critically important because often you can be the first to notice when someone is struggling. I want to thank you for the work that you do and for being here today. We can move on. So a couple of quick housekeeping notes. As you may have heard, the webinar will be recorded. By attending, you consent to being recorded, although I believe everyone's mics and cameras are off, so the only voices you'll really hear are mine and my colleagues. During the webinar, please do feel free to submit questions and feedback in the chat. There will be a dedicated Q&A time at the end, depending upon how much time is available. Participants are muted upon entry and videos are turned off. If there are any technical assistance questions, please don't hesitate to reach out to us through the chat. As I've mentioned in the chat, all the people who registered for this will have the presentation materials sent to them. And the recording will eventually be available on YouTube, although I believe all people who are registered can access and have a link to do so. The last thing is the classic disclaimer that the views expressed in the webinar do not necessarily represent the views, policies, and positions of the United States Department of Health and Human Services. And we can move on. So this is the agenda, learning objectives for the day. I'm not going to read through it, but essentially we'll do an introduction. Part of what we try to do is really get people familiar or more familiar with what the eating disorders are, some of the things that you can do, resources, tools, and tips. Innately, what our objective is really to increase awareness. These are very complex conditions. They can be very damaging to the people who experience them. And as you'll learn later, they can have very high mortality rates, unfortunately. And so we want to provide information and resources for people who may have questions. And I want to encourage anybody, if you do have questions that we do not get to today, please feel free, reach out to myself, and we will seek to get you the information that you need. We can move on. So as I mentioned, I will do a brief introduction of myself. My name is Jeff Greenberg. I'm a clinical psychologist by background. A lot of my work and experience has been in areas of trauma and trauma work, head injury, brain biomarker research models, and of course, eating disorders. I've had the privilege of leading this program for the last year. And now I'll turn it over to my colleague, Dr. Jean Doak, to do a presentation, to do a quick introduction of herself.
Hi, everyone. Thank you for attending today. My name is Jean Doak, and I'm a psychologist and clinical director at the University of North Carolina, Chapel Hill, Center of Excellence for Eating Disorders. And then I also work with my colleague, Jeff Greenberg, with SAMHSA's Center of Excellence for Eating Disorders as a content expert. My specialization has been in child and adolescent psychology, and in the field of eating disorders for over 20 years. And I've even had some privilege and honor in working in school-based clinics as well. So I hope to bring that experience into today's discussion as well.
Wonderful, thank you. We can move on. The mission of the Eating Disorder Center of Excellence is to really serve as the preeminent federal resource on eating disorders. We do the work that we do, advancing education, public awareness, prevention, treatment, and recovery through educational webinars, which you are attending today, by engaging peer-to-peer communities which have been set up. We are currently working with groups of behavioral health clinicians, as well as peer recovery specialists, for a focus on those who experience eating disorders as well as substance misuse challenges. And then the last resource thing we do is provide a number of tailored resources. These are currently being developed, but they will become available to you through the Department of Health and Human Services after they're completed, reviewed, and approved. We can move on. So we're going to launch a quick poll. People wouldn't mind answering the following two questions. Which of the following statements are true? Know that more than one statement can be true. Then the second question is, what are you most excited to learn about today? The numbers are flying up. Give another 30 seconds. All right, I'm going to close out the poll. Very good. Most folks got it correct. That eating people and individuals with eating disorders can appear physically healthy and within weight recommendations. And the teachers and school providers are often in a unique position to identify early signs of eating disorders. And then excuse me. For the poll, we have a nice mix in terms of individuals who are looking forward to different topics today. So hopefully you get everything that you were looking for out of this. We can go to today's topics and goals and move on to the next slide. Today's discussion is going to be organized around 4 session goals. These are identifying the signs and symptoms of eating disorders within students, how to support students who are experiencing eating disorders, collaboration across school health personnel, parents, and caregivers, and then addressing challenges in working with children and adolescents. Let's talk about the role of school providers. Okay, this is where I'm going to turn it over to my colleague, Dr. Doak, who will be doing the bulk of the presentation. I will be joining periodically throughout. Thank you.
Thank you, Jeff, and welcome again to everybody. We did a similar type of webinar last month, and some of you may have been in attendance and many of you may not have been. And so just as a disclaimer, we have a few slides that are replicated from that previous webinar, just in case those who are attending for the first time today didn't have the ability to review that information beforehand. So, as far as today is concerned, we are hopeful that those of you who are participating today are in some of these roles, either in the school health clinic and in the role of nurses, in the counseling center, or maybe embedded in the health clinic as social workers, psychologists, or counselors, athletic trainers and coaches who have a pivotal role in working with children and adolescents in the school setting, and then also guidance counselors, college counselors, course counselors, etc. Um, Obviously, you know that your role just is not in your professional role, but you interface with adolescents and children in so many other facets of their life. And so this is one of the hopes that we have as far as being able to share this information with you and you explore opportunities and identify strategies in which you can interface with adolescents and pro-social opportunities to navigate issues around eating disorders. Next slide. Okay. You may know this. However, I'd love to be able to review why school providers are really, really critical within the school setting as far as navigating issues around eating disorders with children and adolescents. And so what we do know is that the prevalence of eating disorders in children and adolescents really are at one of the peak points in our developmental stages throughout the course of our life. Entry into puberty is a risk factor for children and adolescents. And so for sometimes elementary, late elementary, middle school, and high school, this demonstrates a population that are largely at risk for the developing of an eating disorder. You are with children and adolescents, your students all day, every day, Monday through Friday during the school year. And for some of you folks out there around the country, the school year may be year round as well. So you have even more proximity to students who may have an eating disorder. And then working with students who have an eating disorder, as with any other mental health issue, is a shared responsibility. And so there's a lot of onus and responsibility for those in the school environment to oversee, manage, implement strategies for students across multiple mental health related issues. But our hope is that we can provide information that will be easy for use and is not an increased burden for you to incorporate within your school setting, and the information that you could also take back to your community. And then we also know that school providers often don't have a lot of information around how to support students who have an eating disorder, how to identify whether or not a student has an eating disorder, and even what the next steps might be if there is an awareness that a student might have an eating disorder. And so the course of our time today will review a lot of these opportunities to gain that information and to provide additional resources for you. Okay, so many of you, as I mentioned earlier, are in positions in which you are on the front lines with your students. And so because of that, you have an opportunity to be a change agent in their life, a pro-social individual who can act on their behalf and be able to identify areas of concern. And so some of these roles that we carry in the school setting would be promoting positive behaviors, pro-social behaviors, if y'all are familiar with the term pro-social, and then increase or raise awareness around certain critical issues in students' lives. One of the things that we'll tackle today is developing an understanding of how to identify an eating disorder. Again, we know that your role within the school setting is not diagnosis per se, but you can have a role in early identification, and we can talk about the importance of early identification as we move through the slides. And then even more importantly, I think I saw in the poll around one of the things that y'all are most interested in finding out today: how can you support a student who has an eating disorder? In what way can you communicate or convey that support? And in what way can you incorporate an extended community of support with parents and caregivers? So we'll tackle that as well. one of the things that we want to share is that we want everyone to feel empowered, that they can be change agents in supporting students and within the school community and promoting awareness around eating disorders.
Ian, we're getting some requests. If you wouldn't mind speaking up just a little bit,
Sure. I'm going
and
to
some people are
actually
having
move.
a hard time hearing.
Thank you. Thank you for that. I'm going to change a speaker and see if that makes a difference as well. Okay, is this any better? Or is it about the same? I feel like I'm at the eye doctor. The same or different?
We're getting a lot of yes, that's better.
Great, great. Okay. All right. So we're going to spend a bit of time talking about eating disorder facts, and we'll review this information as it relates to prevalence rates and other data points. So one of the things that we do know about eating disorders, and Jeff alluded to this earlier, is that there is a very high mortality rate that comes along with eating disorders. And eating disorders results in over 10,000 deaths annually. And what that equates to is about one death per hour, almost every hour. And it is a morbid statistic, but it's a very real statistic and one that we use to increase awareness. And what that also equates to is that during our time together, during our 1 hour webinar, that would mean that someone in the United States will pass away from having an eating disorder. So these are very sobering statistics, very sobering pieces of information, but it's intended to demonstrate the critical need to share this information as well. So eating disorders do have the second highest mortality rate of any mental health disorder. And this was a shift actually. Up until about 5 years ago, eating disorders had the highest mortality rate of all mental health disorders. And currently eating disorders fall second only behind opioid use disorders. And the greatest contributing factors related to mortality rates are threefold. One would be cardiac related issues, another would be electrolyte imbalances or instability, and a third would be suicide. And despite these statistics, we also know that 9% of the US population will have an eating disorder at some point in their lifetime. I mentioned that adolescence or pubertal timing is equated to having one of the peak development points of having an eating disorder, and there are others. We're going to focus on adolescence, obviously, because we're talking about the school environment. This is where most adolescents are. But just know that there are other points during the developmental spectrum in which there might present more at-risk opportunities to the development of an eating disorder. So despite these prevalence rates, one of the things that we also know is that only about 20% of individuals with an eating disorder actually ever receive treatment. So we're not doing a great job with that. We're either not doing a great job at identifying the need for treatment, providing information around treatment, decreasing barriers or access to care. And so one of the goals that we have for you today is to share resources that you could take back to your schools, take back to your communities, and it would be a way for you to share a lot of information around eating disorders, as well as how to find information around treatment opportunities. Okay. Let's review a few myths around eating disorders. The first poll that we put up touched on some of these, but there are so many myths around eating disorders, and we get questions about this often, so we thought it would be important enough to include in a slide. So we do know that eating disorders can affect any body size, weight, or shape. And we know that individuals who have an eating disorder can be any size, weight, or shape. So a common myth is that someone who has a normal or expected typical body weight cannot have an eating disorder. Another very, very common myth, and this is where y'all come in as well, is that you can grow out of having an eating disorder, that it's just a fad, it's just something that's short term or short lived, and that getting healthy is just about eating more or eating less. That is it. Another myth that we are confronted with often is if somebody accesses inpatient treatment, that they are then cured or in recovery for an eating disorder. And we know that that is not accurate. Another myth is that eating disorders are based in vanity or attempts at seeking attention, or that eating disorders are an attempt to punish parents or loved ones or caregivers, or that eating disorders are just a choice. If they can choose to have an eating disorder, they can choose to not have an eating disorder. That is a very common myth. And another common myth that parents and family members often really struggle with is that parents are contributing factors or have caused the eating disorder. So, just as much as we spent time on myths, let's talk about the facts related to eating disorders. Next slide. Okay, so facts about eating disorders. There's a wealth of evidence to demonstrate that families are absolutely not to blame for the development of an eating disorder, and even more, that they can be a critical component of treatment, especially in child and adolescent treatment for eating disorders. They're essential in the treatment process. We also know that an eating disorder is not just a mental health disorder. It causes a great deal of physiological or medical compromise. So it's a serious health crisis. It affects multiple areas of an individual's daily living. And as I alluded to in the previous slide, the eating disorders are not choices, just the way depression is not a choice, anxiety is not a choice, ADHD, etc. Mental health disorders are not choices. They're mental health disorders. There is something called a biopsychosocial model that demonstrates the etiology or the development of how an eating disorder comes to be. And what that means is that it's an interplay between genetics, it's an interplay between personality constructs, it's also an interplay between environment or social context. So genetics alone don't contribute to having an eating disorder. And genes and the environment, as I mentioned earlier, can intersect in various ways to develop the eating disorder. Many people, as I mentioned in the previous slide, can be of any size, weight, or shape and have an eating disorder. It demonstrates that there are often missed opportunities in early identification of an eating disorder. It doesn't always manifest in the way someone looks. It can, but not always. And when I mentioned the mortality rate, I mentioned that one of the components related to the mortality rate would be suicide and medical complications. And then, if anything, if any piece of information you leave with today, it is going to be the last bullet point on this slide, and that full recovery is possible. And one of the things that we know about recovery rates is that early identification and early access are keys to that recovery process. Next slide. So let's talk about the eating disorders in school settings. You know, we can't talk about children and adolescents without talking about social media. And so, some of you who may be paying attention to the news are probably all pretty aware of some mention of social media and the impact on eating disorders, particularly around platforms that promote thin inspiration, skinny talk, etc. And you may have heard the word algorithm being tossed around. We are all susceptible to all algorithms in social media platforms. So with children and adolescents, it's no different. But the American Psychological Association has done research recently around the risks of adolescent use for social media. And one of the things that they've identified is that platforms built for adults are not suitable for adolescents. And there's a whole host of research and rationale behind that. The primary rationale behind that is brain development. And so many of you are already aware that adolescent brains are not like adult brains. And there's a large thrust in brain development that occurs around puberty. So around 10 to 13 is when we see a large shift in some brain development. But brain development, as far as adolescent period, lasts through the age of 25. And so chronological age does not necessarily equate to social media readiness. And what we do know about the algorithms is that it can increase psychological harm as it can drive adolescents' exposure to taking health risk behaviors. And so that's one of the reasons why this is a special point of attention. And some social media platforms have been called to task around these algorithms, particularly around the dangers and harmful effects of promoting eating disorder or pro eating disorder behaviors. So, one of the things that we have heard from many of you is that it's always really helpful to weave in a hypothetical student situation into our webinar. And what we try to do is build a conglomeration of behaviors around this hypothetical student. Even though it's hypothetical, many of you probably come across a student very much like Jordan. So I'm going to run through the slide, and I am going to read some of the content on the slide just for thoroughness, but I would encourage you to read along as well. So in this scenario, we're going to review presenting concerns, assessment by a school nurse, a little bit of school background, and some changes in behavior that we have received from teachers. So Jordan visits the school nurse, and Jordan, in this scenario, is a female. She is complaining of frequent headaches, difficulty concentration, and feeling cold more often than not when others around her are feeling comfortable. During the school nurse assessment, the nurse assesses that Jordan has kind of a low to normal blood pressure and heart rate, which is not typical for Jordan. Increased reports of fatigue and poor sleep, and then just offhandedly mentions feelings of guilt around eating behaviors or eating certain foods. And some additional background information about Jordan is that she is a high achieving student, and that she is incredibly active in lots of social opportunities at school with regard to clubs and plays on the varsity soccer team. And in wanting to get a little bit more information about what might be going on with Jordan, some additional information that was shared by teachers was that she has been engaging in a lot more conversation related to fitness influencers, talking a lot more about eating, specifically around clean eating and following related accounts. Talks about Instagram and TikTok accounts that she's following, and has a increased hyper focus around calories, the term of like earning food through exercise in a way to offset the food. And then teachers have also observed some weight loss in Jordan over the past few months. And then those who monitor the cafeteria have noticed that she hasn't really been eating very much at lunch, or she finds other opportunities to not be in the cafeteria. Or when she is eating, the quality or quantity of her food has changed dramatically. So that's a hypothetical scenario with Jordan. And Jordan, I think, also made an appearance in our last webinar. So for those of y'all who were in that webinar, Jordan might be a familiar student case for you. So let's talk about Jordan's care and recovery journey. Interestingly, her first point of contact was with the nurse, and it wasn't specifically around eating disorder behaviors or symptomology. It was around the frequent headaches and difficulties concentrating in class. So this provides an opportunity to be curious and to ask all sorts of questions, in addition to taking the orthostatic information into account as well. And then as far as asking the questions, so she or he not only asks around the difficulties in concentration, the increased fatigue and the headaches, etc., tries to get a little bit more of a picture about what might be contributing factors. The nurse also inquires around stressors, mood changes or shifts, and also explores some questions around eating patterns and eating behaviors. So from that information, the nurse has enough of a concern to share that concern with Jordan, and also identifies the opportunity to share the concern with school providers and counselors where there is a decision to meet with the parents, meet by phone or meet in person. And in that meeting, again, I mentioned earlier that we don't expect any of you to be so well versed that you could diagnose an eating disorder in students, but y'all are all very well versed in identifying behavior change and sharing observations. And so in that meeting, that's exactly what you're doing, is naming that there have been some shifts in behaviors that y'all have observed in working with Jordan and being with Jordan, having Jordan on the soccer team and various clubs. And then you're sharing those observations within the context of expressing concern. Over the course of this meeting, there is an opportunity to assist and align with parents, stating that although the school environment are not experts in eating disorder care, there is an opportunity for Jordan to obtain an eating disorder evaluation, just to rule in or even rule out the possibility of an eating disorder. And the goal of that is multifaceted. One is that you just want to make sure that Jordan has access to care and services that are beyond the scope of the school environment. Two, if there is an eating disorder, you want to provide that opportunity for early identification and early intervention. And then three, there will be that opportunity again to demonstrate your level of support within the school environment and in alignment with the parents. And so that leads us to the next part of Jordan's recovery journey, this idea of wraparound support services. It is not uncommon at all that whenever we work with students with regard to eating disorder treatment, certainly during the school year, we have active communication with schools and with various members within the school setting. Some parents like to navigate that communication themselves, and they like to be the bridge, so to speak, between treatment teams and the school environment. Some parents are more than happy for treatment providers to have direct communication with schools and those involved in the school setting. Next slide. Okay, so let's talk about clinical actions within the school setting. So one of the things that we do know is that there are a whole host of opportunities to foster positive environments for students. And y'all already do this in all sorts of ways. You may be able, or you may already be doing this around mood related issues. So whether it's depression or anxiety, you may also be doing this around learning difficulties, whether it's ADHD or some other learning diagnosis. And so eating disorders also present an opportunity to create or foster a positive environment for students. Many school settings or school districts have nutrition curricula. And so within the context of school curricula, one of the things that we want to propose is that there could be some modification in the way that curricula is presented, particularly around word choices or things that are being focused on. So one of the things that we would love to see in the school environment is a focus on balanced eating. So a removal of terminology from good food, bad food, healthy food, unhealthy food, junk food, etc. We want to eliminate all of that from the curriculum, and we would rather incorporate the word balanced. And so that is a shift for some health curriculum. We also want a shift away from body size, weight, and shape, and more so around how a body can function. In what ways can a body function for optimal mental health? In what ways can a body function in order for individuals to have optimal cognitive health, cognitive flexibility, etc.? Then we also want to foster an environment around body positivity or body acceptance. And so some of this we know from for children and adolescents is the way they feel around their body almost always equates to how they feel about themselves. So issues of self-esteem and self-worth. So we never want to inadvertently create a message that some bodies are good, some bodies are bad, some bodies are fat, some bodies are bodies are thin. Instead, we want to create this environment that all bodies are accepted and all bodies are okay. Additionally, we work with a lot of students who experience weight-based teasing and bullying. And for any type of bullying, I know many school districts and many schools have an anti-bullying policy. Sometimes weight-based teasing slips under the radar at times. It can be really passive, kind of indirect, sometimes overt, and sometimes direct. So we want to make sure that that no bullying policy extends to weight-based teasing. And then we want to also foster a positive food environment or a supportive food environment. I mentioned earlier about the removal of the terminology of good food, bad food. Um, Something I very much am aware is that the school hours of the day are required to fit so much in such little time. And so sometimes some of the things that get squeezed for time could be lunch or various other types of activities during the day. We hear from students all the time that they hardly have any time to stand in line, purchase their lunch, eat their lunch. So if at all possible, we would like the maximum amount of time available within the schedule for adequate time to eat lunch. And then we want to ensure that there's never any messaging that food is used as a reward or punishment. As with many school communities, you engage families all the time around all sorts of things. And so, within the context of eating disorders and positive or supportive eating habits and body image related issues, we would love that opportunity to engage parents in some psychoeducation and awareness around that. You in the school environment can only control and contribute so much. And there's also so much that happens at home. And so, this provides a collaborative joint partnership. And then we also are hopeful that with this webinar and additional resources and information, you're going to be armed to be able to recognize the warning signs of an eating disorder and be able to disseminate that information across your school setting. And then we'd also love school environments to promote inclusive physical activity. And so it's really promoting physical activity within the context of fun and health promotion, and also the emphasis on positive mental health impacts rather than around weight control. Inadvertently, there are a lot of messages that students pick up on that they need to make a certain weight, especially around sport related activity, that they could be quicker, faster, stronger if they lose X amount of weight. And so, to whatever degree possible, we would want to move away from any promotion of physical activity that is weight based. Next slide. So let's review some of the common types of eating disorders. And there is still yet a lot of information that we're going to review. So I'm not going to go into great detail about these, but some of these you're familiar with and some of them you may not be. So anorexia nervosa, and these are listed alphabetically. So anorexia nervosa has a defining feature of an intense fear of weight gain and an increased or decreased food intake. So increased restriction, decreased food intake, often leading to a significantly lower weight than expected or based on their growth curves. So we usually see individuals who've lost a lot of weight or a significant amount of weight with anorexia nervosa. The next category or next diagnosis is commonly referred to as ARFID. It's an acronym for Avoidant Restrictive Food Intake Disorder. We see this more often with children and younger adolescents, although with increased awareness, we're starting to see it more so with adolescents, young adults, and older adults. And the defining feature here is an eating or feeding disturbance manifested by failure to meet developmental milestones around nutritional and energy needs, which can contribute to low weight. So for some individuals, this doesn't create weight loss or doesn't contribute to weight loss. There just may be long-standing low weight. And there are three broad categories associated with ARFID. One would be overall disinterest in food intake. Another category would be an aversion to food textures, tastes, smells. So we see an overlay with autism more often than not with ARFID. And then a third category is food aversion after traumatic event. Traumatic event could be something like a severe allergic reaction or an intense or severe vomiting reaction. Binge eating disorder is another eating disorder category. So it is defined by binge eating behaviors. And binge eating is eating an unusually large amount of food in a discrete or short period of time, accompanied by a sense of loss of control. And with bulimia nervosa, this is where there's some components of binge eating disorder, some components of anorexia, but it's a standalone eating disorder. The defining feature with bulimia nervosa is binge eating episodes, so similar to binge eating disorder. However, with bulimia nervosa, there is also a use of inappropriate behaviors to compensate for the food intake. So it might be extreme periods of restriction, purging behaviors, hyperexercise, use of diuretics, or anything along those lines to try to rid the body of food. And then the final category is OSFED. That's an acronym that stands for Other Specified Feeding and Eating Disorder. It's a little bit of a misnomer in that the defining feature here is it just doesn't meet the full criteria of all the other eating disorders, but it doesn't mean the severity is any less. So it's just something to keep your eye on there. Next slide. Okay. So we talked about early identification and how do you identify things early? Well, you become familiar with the warning signs and risk factors. And so we've touched on some of these already, but they're important enough for me to read through some of them. So I invite you to just read along with me. So similar to the case with the hypothetical student of Jordan, there may be some increased in frequency in talking about food, weight, shape related behaviors. There may be some significant shifts in weight, so increase in weight or weight loss, or even just fluctuations in weight. There's also some mechanisms or behaviors in an attempt to rid the body of food. I mentioned earlier with bulimia nervosa, there may be a use of diuretics, diet pills, laxatives, etc. What is really core with many of the diagnoses of an eating disorder is a denial of the severity of the illness. And so this may come across as defensiveness, maybe even ambivalence, and that's pretty typical within the context of their inability to fully appreciate how severe the eating disorder actually is. We talked about the medical complications earlier, and it can encompass all sorts of different kinds of medical complications. When we talk about, and those nurses who are familiar with orthostatic changes with regard to heart rate and blood pressure, you typically see dizziness, lightheadedness, fainting. So we see that often. Sometimes there can be some GI distress or GI problems, gastrointestinal problems is GI. And then for some extreme cases, there might be some hair loss and also some other physical signs with the skin. We mentioned the behaviors around diuretics, and then similarly, there might be purging behaviors, restrictive behaviors, and compulsive exercising. And then one of the things that we know, and I think this message needs to be reiterated over and over and over again, is that eating disorders flourish in secrecy. And the reason why is there's a great deal of shame and guilt associated with eating disorders. And so you might find that individuals hide their eating behaviors, hide their exercise behaviors, and will not be forthcoming around all of these behaviors. And as far as risk factors, I mentioned already that there are some key developmental transition periods. Adolescence represents one of those peak areas as well. Patients who have other medical morbidities, probably the more common one would be gastrointestinal issues. Diabetes as well is another pretty common one. And adolescents or students who are in high performing sports activities are at increased risk for developing an eating disorders. And certainly students who have a family history of an eating disorder or even any other mood or mental health related disorder. And then what we also know as well is that veterans are also a high risk category of individuals. And so you work with many students who may also have veterans as family members or parents. So just something to keep an eye out for. Okay. I talked about early intervention earlier and how that's one of the key components to recovery. So let's talk about prevention, early identification, awareness, and then treatment. And just let review a few things to keep in mind that'll help you categorize behaviors. So we're going to start in the green and we'll work our way up the slide. So for prevention, or one of the things that we think about as far as pro-social behaviors that give us an indication that maybe things are not of a concern in the context of an eating disorder. It would be choice of food around hunger and satiety cues, and choice of food around preference, not around rules, not around calorie content or food content. Eating freely and at liberty in social settings, eating without guilt or shame, feeling comfortable with one's body. I just want to name that adolescence is a huge surge of change for body change. And so that one may be a little bit tricky for some of our children and adolescents. Having a healthy weight or an appropriate weight for their age and their growth curves, and then eating for just overall enjoyment and well-being. So those would be areas in which we would not be concerned about an eating disorder. The middle section is where we're going to talk about an opportunity for early identification, and this is where our curiosity is piqued. Any abrupt or increased change in eating behaviors, whether it's dieting, fasting outside of any religious kind of fasting period, social withdrawal, not eating with friends or in social settings anymore, increased exercise. Sometimes athletics could be used as an excuse for that increased exercise opportunity. So coaches and athletic trainers are in a unique position to have a critical eye around that. An abrupt change in food preferences, eating behaviors, etc. Hyper focus on food content, weight, calorie content, increased anxiety around food or avoiding food in social settings, body section, body checking or body dissatisfaction. And what we also know is with any changes in caloric intake, there's a direct impact on mood and anxiety related behaviors. So we saw that with Jordan, there is a shift there. And so that piques our interest. And then of course, weight fluctuations. And then in the upper category, this is where we know that treatment might be needed. So engagement in binge eating behaviors, vomiting, laxative use, or any type of other purging behaviors to compensate for food intake, restrictive eating behaviors, not eating enough, rapid fluctuations in weight, the lightheadedness, dizziness, feeling cold or cold intolerance is what we often refer to it as. For females, there could be a shift or change in menses if they are regular with their menstrual periods. And for individuals who have purging behaviors, there could be some swelling around the jaw area. It's called a parotid area. And so that is a physical sign or symptom. And then dehydration and compulsive exercise. These are all very, very common warning signs that treatment may be needed or necessary. Next slide. Okay, so how do you refer students to care? So these are some of the things to consider. So, we get questions all the time like, how do I have a conversation with a student if I'm concerned about an eating disorder? And I want to name that I've worked with so many of you over the years, and many of you may already have the tools in your back pocket already because you already have difficult conversations with students. And the things that I think of more often than not are if you have a concern about a student's mood, if you have a concern about students' anxiety or behaviors that interfere with their ability to follow through with the academic day, if individuals are presenting with any kind of learning difficulties. And so you are already armed with having difficult conversations with students. So I really want to encourage you to use the tools that you have to approach students who might have an eating disorder in a similar way. And then we'll also be able to, in a few slides, we're going to talk about some strategies or the way you can approach those conversations and expand the toolkit that you already have. And so what may be unique for some situations with students who have an eating disorder is the active engagement with with parents and caregivers. But again, I want to reiterate, you may already do so with some of the concerns that students already have, particularly around mood disorders. Some of you may work with students who engage in self-harming behaviors or suicidality. So you are already engaging parents and caregivers to provide that extra level of support, increase that awareness, et cetera. And so with eating disorders, given the severity, it would be no different than doing so. I think adolescents often present as if this should be mine, this should be private and confidential. It's no one else's business. I don't want to worry my parents. I don't want them to be involved. And this is where you having this increased awareness around the risk factors related to an eating disorder, you can provide that education that actually eating disorders are incredibly risky and do place your health at risk in a very, very similar way as other severe issues. And then we're going to give you resources where you can assist or be a resource to family if they need it in identifying treatment or providers within the community. Okay. And this is just a broad overview. This is nothing that you have to incorporate within the school setting. But when parents or caregivers or even students ask, well, what am I going to expect with treatment? These are just four broad overarching goals around what we tackle in the treatment environment. So the first one, which is always the most critical one, is that we want to get a medical evaluation. We want to make sure we're not missing anything that might be physiologically severe or create medical instability. So the first primary treatment goal would be medical stabilization. And then shortly or around the same time, we also want to work toward weight restoration. And that almost always is equated to increased food intake and increased variety around food content as well, and increasing the repertoire of food choices. Relatedly, we want to work on normalizing eating behavior. So having a return or a start of eating in a regular eating pattern. So eating a breakfast, a lunch, a dinner, maybe even having a mid-morning snack and a mid-afternoon snack. And then, of course, as we are all social beings, we want to work on reintegrating the student into their normal developmental adaptive social environment. Next slide. So one of the things that is new, and I don't remember exactly what year this came out, but it's been within the last few years, is that eating disorders now qualify for 504 accommodations. So this is fantastic because one of the things that we do know about eating disorders, and I hope that I've conveyed this today, is that eating disorders affect all domains of living. So not just the school environment, but every aspect of living. There's some specific implications in the school environment, and that's what the 504 accommodations can provide for. So, for those of y'all who are going to be looking for additional information, don't worry, we're going to provide you with a link where you can read about that. But just broadly speaking, some of the 504 accommodations spell out accommodations within elementary and secondary schools, as well as schools beyond. And so we can talk about those differences in a little bit. But these accommodations require, obviously, that schools provide modifications and other accommodations related specifically to the student's needs, often related to a specific treatment plan in place. And then the shift, as many of you know, is that schools take on a very different role in elementary and secondary school environments. And so for those of you who are working in the high school environment and know that a student will continue with 504 accommodations in post-secondary schools, you can provide education around how that shift becomes them being the primary one who's responsible for their advocacy, ensuring these accommodations are in place, et cetera. So this is a very brief overview. As I mentioned, some of the things that are afforded in 504 for elementary and school environment, and then secondary school environment, and then things that are afforded in the post-secondary school environment. So giving alternative assignments with regard to physical education, health curriculum, nutrition classes, offering alternatives around food-centered activities or events, allowing extensions in assignments. So whether it be time, test completion, etc. And this is, obviously you afford these accommodations as the school environment is able to, but these are just some examples. excusing students for medical appointments. And I will say eating disorder treatment is a multidisciplinary team approach. So students will have multiple appointments during the school day, across several days of the week at times, especially early on in treatment. And I'm just keeping track of time. We have about 6 minutes left, so I might move through the next set of slides pretty quickly. So different levels of care are afforded within eating disorder treatment. And so our highest levels of care may require a student to withdraw from their school district and enroll elsewhere or have some collaborative arrangement made with the home school district. Absent policies may need to be examined carefully with regard to 504 accommodations. And then students with eating disorders, especially early in the treatment process, may have to abstain from any kind of sport or physical activity to allow for the opportunity for medical stabilization. So tools and tips, we're going to quickly go through these. So I mentioned that y'all already have some of these tools. And so as with other sensitive topics around mood or anxiety related issues, we want you to approach the situation with a student with curiosity and sensitivity at the same time, where you can utilize supportive language. So no judgment at all. Instead of saying, I've seen this, I've seen that, you can say, I have noticed that you seem really tired, really distracted lately. How are you feeling right now? Instead of saying, I've noticed some changes in your weight. You look like you've really lost a lot of weight. You look like you've gained weight. That's the language that we want to avoid. We want to focus on observation of behaviors, not on diagnosis at all. And we want to call that special attention to the high risk groups. So individuals who already have a mental health diagnosis, individuals who are high achieving, individuals who are involved in sport activities. And then we want to promote and encourage open communication. Okay, so tips for involving parents. Again, you do this probably more often than not when it comes to mood related issues, self harm, or even SI. So it is providing that open channel of communication between the school environment and parents. It's approaching the communication from a place of concern and sharing observations, accompanied with empathy and alignment with them and joining with them. Again, not making a diagnosis. Sometimes parents just want to know, well, what is my child's diagnosis? And just reiterating that you may not be in a position to provide a diagnosis, but you can provide a collection of observations and be a resource to them in coordinating care for them. And then clearly communicating to them that the school environment can absolutely be a supportive environment for the student and for the parents, and that you can assist in determining what the next steps are. So all of that empowers school providers and provides reassurance to parents. And then again, I really want to reiterate that you already have some of these tools in engaging in difficult conversations with parents and with students. Next slide. Okay, so we're going to move on to recap and close out, and then we're going to save the last few minutes for a Q&A. Okay, so recap of lessons learned. So we talked about the role that y'all have in the school community, particularly as y'all interface with children and adolescents, and in what way your overview of eating disorders can contribute to being better equipped at identifying some of the early signs, warning signs, risk factors, etc. And then even being in the front line, potentially, of being able to be an early identifier of an eating disorder and facilitating that referral to specialized treatment. And then we also reviewed in what ways you may be able to engage students and parents within the communication and conversation around all of the observed behaviors and the coordination of care for specialized treatment. So I mentioned earlier, we're going to give you a suite of resources, and please don't worry, you are going to be receiving all these slides with active links. So just know that these are broken down into categories of general information around eating disorder. There are links provided there. Educator-specific eating disorder resource, fantastic resources that the National Eating Disorder Association has for school communities, for educators, etc., navigating eating disorders in the school setting. And then you'll also have the link for the 504 accommodations. Okay, so let's pause in me talking and you asking questions. And for those of you who are able to stay on a little bit longer, I think some of us have agreed to do so. If you're willing and able, we're happy to answer whatever questions that you might have.
Jane, one of the things that's come up, there are a lot of questions around sort of causes or theology around what eating disorder, what causes eating disorders. And I think one of the things that it's really important to understand is that individuals who have or are experiencing eating disorder, they need help first and foremost before we get to the foundations of why did something occur. You can work through that within the course of care, but kind of like if it was a physical injury, you would be less concerned about how did somebody break their leg. You would be more concerned about getting them to the hospital and trying to fix the leg. So that's one of the key elements. And I think the other thing to really think about is a lot of people have been talking about how eating disorders are sort of they look a lot like a lot of other conditions where they sort of map onto. One of the things I've been trying to produce in terms of responses is that it is really important to understand these are complex. They are conditions that overlap with each other. Eating disorders coexist a lot with substance use disorders, as we've talked about in the past. Eating disorders coexist certainly very heavily with mood and anxiety problems, developmental challenges. The If you can kind of distill this down to a key point, the two most important things I think we can agree on is early identification, first figuring out when somebody is starting to experience these challenges. And then secondarily, getting people into the care and support that they need. It is not it is not an overstatement to suggest that when somebody has a very full-fledged, long-standing eating disorder, care is very complex and recovery can be very difficult. However, if we move into the world of prevention, early identification, early intervention, then we think we see the best outcomes for people, and that's probably the best place to put a focus on.
Absolutely. And especially for children and adolescents. Children and adolescents represent a developmental time where it's the first onset of the eating disorder. And that is really the most critical point of intervention and treatment as well. And so if we can offset that and not delay treatment, they have a greater chance of optimal recovery as well.
Wonderful. We had a question that came up about obviously we're focused on adolescents and youth because of the school-based presentation, but there have been some questions that have popped up about sort of military and people getting ready for military physical fitness and the risks there. Individuals who may be even a little bit older, if you want to kind of make a comment about that.
Yeah, I appreciate that question. Working with individuals in the military context is a challenge because there are physical requirements associated with their ability to serve, enlist. Service academies also have specific requirements. And so it is a delicate opportunity for intervention. And so ultimately, we never want anybody to feel as if they have to engage in eating disorder behaviors in order to meet specific physical requirements. So sometimes it is providing information and education around the risks of the behaviors and in what way there could be a balance between working toward those physical requirements and being able to engage in daily living in a healthful way. For some individuals, it's not possible because they do have an active eating disorder. So then that would foster some really, really difficult, tough discussions around whether or not that route is the best route for them at this time. And then the other thing too is that it is not uncommon. I work at our facility is located on a college campus, and so we have the benefit of a counseling center and health center being located here who are very well versed in eating disorders. And so we work with a lot of undergrad and grad students and health professionals who may have never had treatment before and is now for the first time being diagnosed. And their eating disorder is so very severe that they may actually have to withdraw from their academic their academic curricula at that point. So it's not uncommon that we work with students who withdraw for a semester, a year or more. Again, those are really, really difficult, tough conversations to have. But the emphasis is that this is a health crisis and a mental health crisis at the same time.
Great, thank you. There are questions about resources. I'll address that because I'm feeling comfortable to do so. There will be a lot of resources that you'll be able to access through the slides, including live links. The Eating Disorder Coalition and various eating disorder foundations around the country actually have quite a lot of good resources. One thing that I think Jean would be helpful, and then we'll probably close up after that, is there are a lot of questions about starting the conversation, having the conversation with the parents of a child who may be at risk for or seems to be experiencing the early signs of an eating disorder. Could you talk just a little bit about that and how you start that conversation, how to prepare for it?
Yeah, I think, one of the things that we experience from parents is that hearing information that their child may have a mental health disorder can be shocking, could be surprising, could also be met with a little bit of defensiveness, not in the context of them not wanting to support their child, but within the context of maybe this is new information to them. And so we want to be mindful of that in a very similar way that we would approach families around medical diagnoses. And so I think when we think about individuals in the school environment, one of the keys is sharing information with parents and families that are observational, that are really based in a shift or a change in behaviors. You work with these kids all day, every day, and many of you get to know them really well. And so you know what's typical for them and you know what might be different. And so it is the foot in the door, so to speak, is saying, hey, I just wanted to reach out to say, I've noticed some different changes, or we've noticed some different behaviors with Jordan, for example, our hypothetical student. um, not only physiologically, she's coming to the nurse more often, but also some of her teachers are reporting that she's having a hard time concentrating in class. She's turning in assignments late, etc. And so we want to incorporate you into the sharing of observations. And we also want to be mindful that these shift in behaviors can be an indication of a couple of different things. It could be related to a mood disorder. It could be related to an anxiety disorder. It also could be related to an eating disorder. And so to rule out any of these possibilities and to try to get Jordan back on track in the way that she had been functioning before, we think it would be worthwhile to seek out an evaluation. And sometimes another foot in the door is maybe you can ask them to meet or have a conversation with their pediatrician. Their pediatrician is somebody who they've probably had a very long-standing relationship with. And their pediatrician may be well versed in being able to pick up on some of these signs or symptoms, especially if they've seen them at their annual exams. And this might be a point of contact in between those annual exams. So that could be a trusted resource for a family. And that is a great foot in the door that where you can tread a little lightly in having a difficult conversation.
Wonderful. Thank you so much, Jean. I really do want to thank everyone for being here in attendance. This is a fantastic outing, and I appreciate all the interaction, the questions, the comments. Um, you know, remember that for you, as people involved in individuals' lives, you can do what you can do, which is no more, no less. It takes multiple people to help somebody get better. And if you are doing your part, then you should feel very confident in what you're able to do and what you are doing.